joining the webinar today. I'll be talking about cortisone injections for knee osteoarthritis, helpful or harmful. So I chose this topic today because most of the patients that we see with knee osteoarthritis have usually tried a cortisone injection. It's still considered standard of care in orthopedics as a first-line injection treatment. For example, if you go to an orthopedic surgeon with knee pain, you have x-rays or diagnosed with knee arthritis, if you don't need surgery, they'll usually send you to physical therapy and they will offer you a cortisone injection. And there are three common scenarios that we see in patients that get these cortisone injections. One, a lot of patients say it didn't work. Two, it's a diminishing return. So patients with the first injection sometimes will get 3 to 6 months of relief. Second injection only helped a few weeks, and the third injection didn't help. Or three, we see many patients that get these cortisone injections repetitively every 3 to 4 months to help manage the pain. But unfortunately, most of the patients aren't aware of the potential risks of getting cortisone injections, especially repetitive injections. So I'm going to review some of the evidence regarding cortisone and the potential harmful effects on joint cartilage and discuss what we believe is a better injection option for knee arthritis. So cortisone is a synthetically manufactured injectable drug that resembles cortisol, which is a naturally occurring hormone produced by our bodies. It's used in orthopedics to treat inflammation in joints or around tendons. Cortisone injections are also known as corticosteroid injections or steroid injections, not to be confused with anabolic steroids. Benefits of cortisone injections: they are a very potent anti-inflammatory, so they can reduce pain and inflammation. They're fast acting, so patients typically get relief within a few days to a week. They're readily available and covered by insurance. Some of the limitations: they're often considered to be a temporary fix because they don't really heal the underlying injury. Relief is typically short-term, usually a few weeks up to 3 months. And it's not really considered to be a good long-term solution for most of the orthopedic injuries we see, especially for knee osteoarthritis. What about the harmful effects on joint cartilage? Well, there are multiple laboratory and animal studies that have shown that corticosteroids are toxic to articular cartilage. And this is something that we've known for many years, but now there is a growing body of clinical evidence and published studies showing that corticosteroid injections will accelerate cartilage loss. So let's review some of those studies. So this was a study just published this year in May of 2025 by researchers from University of California, San Francisco, and they looked at patients in a large database called the Osteoarthritis Initiative. This was a multi-center observational study that followed close to 4,800 patients with knee osteoarthritis from 2004 to 2015, and they monitored these patients over time with serial imaging, so regular x-rays and MRI, obtained clinical data, did genetic testing and labs, all to basically create this large database of patients with knee arthritis so that researchers from around the world could access and use this data to analyze and help them learn more about the natural progression of knee osteoarthritis, and also help them develop treatments to slow the progression and modify the disease process. So these authors looked at 210 patients from this database who received either cortisone injections or hyaluronic acid injections into their knees, and they compared them to matched controls who didn't receive any injections. And they followed these patients for up to 2 years with MRI. And they wanted to see if these injection therapies that patients were getting were associated with any progression of osteoarthritis on MRI. And what they found was that patients who received the cortisone injections had significantly higher progression of osteoarthritis on MRI at 2 years compared to patients who received the hyaluronic acid injections or no injection. So basically, they concluded that the cortisone injections were associated with progression of osteoarthritis on MRI. And interestingly, the hyaluronic acid injections were associated with decreased osteoarthritis progression in this study, suggesting that, compared to control, suggesting that there might be some protective effect that the hyaluronic acid could have on the joint cartilage. This is another study published in June of 2019. Again, they analyzed patients from this Osteoarthritis Initiative. This study looked at 684 patients with mild to moderate knee arthritis, and they followed patients who received intra-articular cortisone injections and compared them to matched controls who did not receive injections. And they looked at progression of osteoarthritis on x-rays. And they found that the incidence of worsening osteoarthritis on x-rays was significantly higher in patients who received the cortisone injections compared to those who did not. So they concluded that intra-articular cortisone injections, especially if they received continuous or repetitive injections, may be associated with increased risk of knee osteoarthritis on x-rays. Then another study was published in May of 2020. This was entitled Intra-Articular Corticosteroid Injections Increase the Risk of Requiring Knee Arthroplasty. So these authors analyzed patients again from the Osteoarthritis Initiative. And they found that 796 patients who received cortisone injections, 31.3% of them went on to have knee replacement surgery, compared to 3,026 patients who did not have knee replacement surgery. Only 5% went on to have knee replacement surgery. So they concluded that corticosteroid injections seem to be associated with an increased risk of requiring knee replacement. And this was probably the best study that looked at cortisone effects on joint cartilage. This was published in the Journal of American Medical Association in May of 2017. It was a randomized controlled trial, so the highest level study that you can do, 2-year follow-up, looking at 140 patients with symptomatic knee arthritis. Half the patients were randomized to receive a cortisone injection into the knee joint every 3 months for 2 years, and the other patients, the other half, received a saline injection into the joint every 3 months for 2 years. And they measured the cartilage volume on MRI, so a very accurate measure of cartilage loss by tracking on the MRI. And they found that the cortisone group had greater cartilage volume loss on MRI compared to the saline group, and no improvement in pain. So not only did their pain not improve, but they had loss of cartilage at 2-year follow-up. So pretty compelling evidence that the cortisone is what is causing this loss of cartilage in the joints, and confirming what we already knew scientifically. Here's another study entitled Intra-Articular Corticosteroid Injections in the Hip and Knee, Perhaps Not as Safe as We Thought. This was published by a group of radiologists in December of 2019, and they described different adverse events that they see following intra-articular cortisone injections. They described accelerated osteoarthritis progression, subchondral insufficiency fractures, osteonecrosis, and rapid joint destruction, all related to cortisone injections. Now, is the harmful effect on cartilage only an issue that we see in knee joints? No, it's also well documented in hip joints as well. There's a condition called rapidly progressive hip osteoarthritis following cortisone injections. This is where a patient can develop rapid progression of their arthritis in the hip joint following just a single cortisone injection. These are 4 published studies in the literature, all documenting this complication. These were published between 2018 and 2023, and they found that the incidence of developing this complication was anywhere between 2.8% in one study up to 21% in one study. And they also found that the repetitive cortisone injections or using higher dose steroids caused a higher risk of developing this complication. So we know that cortisone is not good for the joint, but is it still reasonable to use? Yes, we still use cortisone in our clinic from time to time, but we feel that doctors need to be more judicious about when we use the cortisone injection. So some examples where we feel it's still appropriate: if patients need quick-acting short-term pain relief, so they have an upcoming vacation or an important event such as their child getting married, they want that quick-acting pain relief, then in that scenario, the benefits probably outweigh the risks. Or if a patient has severe pain and swelling and need more immediate pain relief, again, in that scenario, the benefits probably outweigh the risks.
Just had a patient 2 weeks ago. He had a full thickness tear of his Achilles tendon, required surgery. So now he's depending on the other leg. The other leg has a meniscus tear, so he develops this large joint effusion in now the other leg, and is having trouble recovering from his surgery. So a very low dose steroid injection gave him complete relief of that knee pain about 2 days, so that he can continue his rehabilitation with the Achilles tendon tear in the other leg. So that's an example of how steroids can play a role. But as you mentioned, it's very limited use. I mean, you and I, that's all we did for 15 years. Corticosteroid
Yep.
injection. We're guilty. We're guilty of having done this. We didn't know, in the 90s, in the early 2000s, that this was a potential problem. But the data, as you've eloquently laid out for us, clearly shows that there is something to consider. There's a flip side to this treatment that we need to be mindful of.
Yeah. And the other thing is that patients get such good relief and so quick that it's kind of like, they're when it wears off, they want to do it again. But now we
Yeah.
know it's not good to keep repeating these injections.
I tell people it's like eating chocolate cake. You feel really good right away, but maybe in the long term, not so good for your health.
Yeah. Yeah. So
You'll
when
eat it.
should we avoid the cortisone injections? Well, as I alluded to, repetitive injections is not a good idea due to the effects on joint cartilage. Doing a series of 3 injections, that's old school, no longer considered standard of care. Using high dose steroids is not good for the joint cartilage. If someone has only mild to moderate pain in that scenario, the risks probably outweigh the benefits. And if someone's looking for a longer term solution for their problem, then the cortisone's not the answer. It's really just a short term fix.
I think that's a really good point. I think in the case where a patient maybe has very severe osteoarthritis, I don't know that we've stratified in those studies the mild, moderate, and severe subgroup cohorts to see if the joint's already severely damaged, how much more harm are we causing, to the cartilage? If you want to be a purist, you just avoid it completely in everybody. But I think being selective is key in all things we do in healthcare.
Agree. Agree. So is there a better option for treating joint osteoarthritis? Yes, we believe that platelet-rich plasma, or PRP, is the superior option for treating joint osteoarthritis and probably should be the first-line treatment, especially for knee arthritis, given the data, which I'll go over. So what is PRP, or platelet-rich plasma? It's where we take a sample of a patient's blood and then we concentrate the platelets out of that blood sample using a centrifuge. So if we take the concentrated platelets plus some plasma, we have platelet-rich plasma, or PRP, and we inject that PRP into the knee joint. Once injected, the concentrated platelet will start to release growth factors to stimulate healing, repair, reduce inflammation, and help the arthritic pain. So what exactly is it doing for joint osteoarthritis? It's not regrowing cartilage, but it's improving the joint microenvironment, reducing inflammation, decreasing the harmful proteins and cells that are causing pain and cartilage loss, promotes healing of injured areas of cartilage and bone. We know it's effective for arthritic pain, and most experts believe that it slows the degenerative process, so it actually has a chondroprotective effect. So it's protecting the cartilage and slowing the progression. So let's look at some of the evidence. Which is a better treatment, cortisone versus PRP? This has been studied extensively with multiple randomized controlled trials, systematic reviews, and meta-analyses showing that looking at this topic. So let's review some of the data. This was a study published in June of 2021. It was a systematic review and meta-analysis of 8 different studies, 648 patients that compared corticosteroid injections to PRP injections for knee osteoarthritis. And the authors found that PRP injections produced superior results compared to corticosteroids for symptomatic management of knee osteoarthritis with regards to pain, stiffness, and participation in exercise and sports at 12 months. Another study, another meta-analysis of 30 different randomized controlled trials of 3,463 patients with knee arthritis treated with various injection therapies. Again, they found that PRP injections demonstrated the best overall outcome compared to cortisone, hyaluronic acid injections, or placebo at 3 months, 6 months, and 12 months follow-up. Another study published in the American Journal of Sports Medicine, September 2022, another systematic review and meta-analysis of randomized controlled trials comparing different injection therapies for knee arthritis. Again, they found that PRP injections yielded improved outcomes when compared to cortisone, hyaluronic acid, plasma-rich and growth factors, or placebo. Another study, meta-analyses of 16 different randomized controlled trials published in March of 2023, 1,652 patients with mild to moderate knee arthritis treated with various injection therapies. Again, PRP outperformed injections of cortisone, hyaluronic acid, and ozone in terms of pain, stiffness, and function. And then another study, April of 2024, again, another systematic review and meta-analysis of 12 studies looking at 801 joints that compared corticosteroids to PRP injections for knee arthritis. Again, PRP injections yielded superior results compared to corticosteroids for alleviating pain and enhancing functionality in patients with knee osteoarthritis. So overwhelming amount of evidence showing that PRP is a superior treatment for pain and function.
Can I intervene real briefly?
Yeah.
Many of our patients ask for the evidence, and you've laid the evidence out here beautifully. At least once a week, I hear a patient tell me that they spoke to their physician, probably a primary care physician, who told them that there was no evidence for PRP for knee osteoarthritis. And as you've just heard, the exact opposite is true. So we prepared a document. It's on our website. If you go to SDOMG.com, go under the PRP section. There's a document you can download. We're on the campaign to educate people and physicians in particular. So feel free to share that document. It's a 25-page document that has a lot of these references and an explanation of what the scientific evidence actually means.
Yeah. And then this last study I'll review was just published last month, August of 2025. These authors looked at all the data that have compared corticosteroids to PRP for knee osteoarthritis over the past 60 years. And they found that PRP injections for knee arthritis have been documented in more studies and larger patient numbers. And there are a higher number of high-level studies documenting superior efficacy and safety. So these authors strongly suggest reconsidering current guidelines that favor corticosteroids over PRP for the treatment of knee osteoarthritis. And what guidelines are they talking about? So the American Academy of Orthopedic Surgeons, their last guidelines for management of knee arthritis were from 2021. In those guidelines, they did recommend PRP as a valid treatment for knee osteoarthritis, stating that it may reduce pain and improve function in patients with symptomatic osteoarthritis of the knee. However, their recommendation for corticosteroids was a stronger recommendations over PRP. Again, these were from 2021 and definitely outdated based on the current literature. And even worse was the American College of Rheumatology guidelines from 2019, very outdated. In these guidelines, they strongly recommended intra-articular steroid injections for knee arthritis and strongly recommended against PRP in patients with knee arthritis. And they cited their reasoning for recommending against PRP was they felt that there was a lack of standardization in available PRP preparations. But these are very outdated guidelines. And one of the reasons why I think insurance companies aren't on board with PRP because these big societies aren't yet updating their guidelines to the more recent literature.
But
So
plus the fact that you just, sorry, the other point, of course, is that the standardization is still an issue. Every clinic has a different way of preparing their PRP. We actually make 5 different PRPs depending on what our goals are with our patients. But and obviously we have the highest standards for making high quality platelet-rich plasma, but that's not necessarily true with all clinics.
Correct. Yeah. So in summary, take-home points. 1, we know that cortisone injections can be harmful to joint cartilage and can accelerate cartilage loss in patients with knee arthritis. Again, we knew about this potential risk for years, but we were still doing it. But now that we have more data, more clear data showing imaging with progression of arthritis related to steroids, it's definitely a concern. 2, PRP injections are superior to cortisone injections for improving pain and function in patients with knee osteoarthritis. Very overwhelming data to support that. And based on the science and clinical evidence, PRP is really the better long-term treatment for the management of knee arthritis. Most of the patients we see are trying to preserve their joint and improve their pain. And so PRP is really the best treatment because we know it is superior to cortisone as far as improving pain and function. And we know it is not detrimental to the joint, but potentially helpful to slow the progression of the arthritis. So I really believe that it should be the first line treatment for knee arthritis, definitely over steroid.
That's great, Dr. Evangelista. If we have 40 people or so, you may have questions. If you go to the Q&A section at the bottom of the Zoom menu there, you can type in your question. We'll be happy to answer it. While you're doing that, by the way, excellent presentation. Thank you for doing that. You almost got it done in the 15 minutes that I asked you to do, but it's great. I interrupted you, so but we could also have a discussion about the use of corticosteroid injections for tendon injuries, which is also still a very common practice in the United States in your typical medical practice. And we haven't reviewed the evidence. We can do that maybe in our next talk. But one thing I wanted to highlight was some data that was presented at a recent medical conference by Dr. Fitzpatrick, who's a physician in Australia, I believe. And she presented her 2-year outcome data treating patients who had chronic hip pain due to a hip tendon tear. And she treated those patients with PRP. Another group was treated with placebo. So it was a randomized clinical trial. She obviously showed superiority with the group that received the PRP for their tendon tear. However, there was a subgroup of patients who had had a prior corticosteroid injection to the tendon. And these patients, interestingly, showed a inferior response to their PRP therapy versus the patients who had not previously been treated with corticosteroids. So we're now starting to see signals, and she hasn't published this data yet. She just presented at this conference. She did publish her randomized clinical trial, but she hasn't published the data on the effect of having had corticosteroids injected into the tendon. And sadly, that is still an extremely common practice. A patient presents with pain on the side of their hip. The first thing the doctor will say is, well, you have bursitis, you need a cortisone shot. And usually that's not an accurate diagnosis because MRI or ultrasound has not been performed. A lot of times the needle goes in the wrong place because it's not ultrasound guided. And if you're injecting steroids into a tendon, it's probably detrimental to the tendon. And now we have evidence that shows that it'll probably also be a negative factor on your potential benefit from a subsequent PRP injection. So that was really nice data that Dr. Fitzpatrick provided recently.
Yeah. All
Okay,
right. Looks like we have a few questions.
yeah, go ahead. You see them?
Yeah. Who is making strides to have PRP insurance approved?
Workers' comp.
Yeah, workers' comp will pay for it. There are some big companies that will pay for PRP for their employees because they feel that it's cost effective. But yeah, with the bigger insurance companies that are for profit, it's they're not looking at the big picture. I feel that it could be cost effective for them because they could be preventing a lot of these patients from going to knee arthritis. But they are really paying for less and less, it seems like. So, but
Yeah, I think the standardization, sorry to interrupt you. The standardization issue is still real. We've been talking about it for a decade about how there really is no standard protocol from one clinic to the next. So even though patients are paying cash for these treatments, many times they're paying for suboptimal care. Suboptimal meaning that the dose of platelets is not sufficient. So we didn't talk about that today, but there's adequate data that suggests that you need at least 5 to 10 billion platelets to have a therapeutic dose. Many of these clinics offer 2 billion or less. So that's part of the problem. The other problem is, of course, not using image guidance, ultrasound guidance to assure that the platelets are going into the right areas in the knee. So this plus some other issues, of course, has discouraged insurance companies from adopting this as a reimbursed service.
All right.
What about L5? What about L5S1 injection? I'm assuming that refers to the it could be, well, there's 3 things you might inject at L5S1. So L5 refers to the 5th lumbar vertebra in your low back. S1 refers to the sacrum, which is the top of your pelvis. It's a very common area for patients to develop degenerative changes. The degeneration usually occurs to the disc or to the joints at that level. There's a nerve that lives right between the disc and the joint. So it's just an unfortunate anatomical situation where you have this very sensitive nerve structure that lives between a disc and a joint that can become degenerated. We have injected the nerve space. It's called an epidural injection. I think between Dr. Evangelista and I, we've probably done 30 or 40,000 epidural steroid injections in our career. And it's actually highly effective. Although if we could have another lecture talk about that. Um, we do believe that there are some negative effects associated with corticosteroids in the epidural space, but it's kind of in the same vein as what you just heard with NeoA. It can provide short-term, quick benefit. In many cases, it can be long-lasting. Typically, it's a bridge to get a patient from a very severe acute situation to more of a low pain situation that they can then endure physical therapy or other forms of therapy that are less invasive. Uh, we also inject platelet-rich plasma at the L5S1 level, whether it's the nerve or the joint or the disc. So there are some other lectures on the YouTube channel that you can watch that cover those topics.
Yeah. Um, are you using PRP for hand osteoarthritis? Yes, we are. We use it pretty much for any joint arthritis where we want to avoid steroid. There's not as much data for hands. We do thumb CMC joint very pretty commonly. But yeah, really you can use PRP for any joint osteoarthritis throughout the body.
The next one's a loaded one, doctor. Isn't bone marrow better than PRP? What is bone marrow? So bone marrow, of course, is the cellular content that's in the center of your bone. It's composed of blood. It's composed of fat tissue. It's composed of bony spicules. There are a small number of stem cells, what we call the mesenchymal stem cell. There's a large number of what we call the hematopoietic stem cell, the cell that actually makes your red blood cells, your white blood cells, and your platelets. So this is where your platelets come from. This is where their parents lived. They are then manufactured in the bone marrow and then excreted into your circulation. By some accounts, up to 10 million platelets made every second in the human body. Amazing. So why would bone marrow possibly be better? Well, for years it was touted as a stem cell therapy, but it really isn't. It's a very low dose stem cell therapy. Perhaps 99.9% of the cells in your bone marrow are not the mesenchymal stem cell, so we really should not call it a stem cell therapy. It does contain molecules, perhaps not for this topic, but you may have heard of a molecule called IRAP, interleukin-1 receptor antagonist. There are other molecules in there that are also anti-inflammatory, which can provide some benefit. There is some good data that aspirating bone marrow from a patient's pelvis, typically is where we would take it from the pelvis, and then spinning it much like you would with PRP, where you spin the blood in a centrifuge, concentrate the cellular fraction, and then inject that as a treatment. And there's good data that is helpful for pain and improving function in cases of osteoarthritis. Whether or not it's better, we can't comment because better is relative to the patient. In PRP, you could argue that in mild osteoarthritis, you could argue that PRP is sufficient, it's cost effective, it's going to be less invasive, and the results are quite good. Perhaps in a more advanced case, you may consider bone marrow aspirate concentrate. And then you have all the same challenges of PRP with the bone marrow aspirate. For example, if your doctor does not know how to aspirate bone marrow appropriately, they are actually aspirating blood. So this is a very invasive intra-bony blood draw when you could just simply draw the blood from the arm. And so there's much to unpack there, but I think when we answer the question, is bone marrow better than PRP, we have to consider it on a case-by-case basis and make sure we're comparing apples to apples.
Yeah, and I was doing bone marrow for several years, and I kind of switched away from bone marrow. There were a couple of studies that came out that were kind of enlightening to me. One was a Shapiro study. I'm not sure if you saw that, where
Of
they
course.
compared bone marrow to a saline injection in
Yep.
patient with bilateral knee arthritis. They inject
Yeah,
one knee with
clear.
bone marrow, one knee with saline, and they didn't see any difference in outcomes between the two groups. So bone marrow wasn't better than saline. And then there was another study, I believe, that looked at bone marrow versus PRP head to head for knee arthritis and didn't show any difference in outcomes. Both helped, but bone marrow didn't stand out to be better than PRP. So yeah, those reasons, another reason I've kind of switched over to doing more fat rather than bone marrow.
And specifically because fat has a higher concentration of these mesenchymal stem cells, something like 100 to 500 times more cells.
Yeah.
If we really want to do a stem cell-based therapy, adipose tissue appears to be a better tissue source. Plus, whenever I would explain to the patient, I'm going to stick a needle in your bone and suck out your bone marrow, they kind of back away. Whereas when I said, I'm going to use a cannula to suck out your fat, they kind of lean in a little bit. And
Definitely
then they
less
ask me,
painful.
take it all. Yes, neither one are typically painful if they're done correctly. But I think most people would prefer to have their fat removed than their bone marrow.
Medicare. No, Medicare is not covering PRP yet. There was one insurance company, TRICARE, that was covering it for a short period of time, but they stopped for some reason.
Outside of orthopedics, I do believe that Medicare covers PRP for certain types of wound healing. So this is a very sad story, but patients can with diabetes can develop these non-healing ulcers of their lower extremities, and they can be limb-threatening and potentially life-threatening. They have these chronic infected wounds on their feet or their heel. And PRP was shown to reduce the amputation rate by 75%. And that data was known for 10 years before Medicare finally approved it as a treatment for chronic wound healing. So I'm sorry to say that, the federal government moves slowly. I don't know if it's any different today, but clearly the data was pretty uh, helpful in helping us realize the benefit of PRP in that particular condition. I think it's going to take a lot more time for us to see change in orthopedics.
Right. Would you recommend PRP or prolotherapy to improve joint stability in the SI joint? Both. I've done both. I've used prolotherapy or PRP, and both can be effective for helping to stabilize the SI joint. We inject the SI joint ligaments to help stabilize the SI joint.
I find that I've done both. I did parallelotherapy in my fellowship back in the mid to late 90s. I have switched now to strictly PRP. Um, I would say 99% of the time simply because I'm finding it works better. I don't need to do multiple injections. Typically with prolotherapy, which is dextrose, sugar water, you're doing at least three, possibly as many as 8 injections spaced over a long period of time. I just find that PRP is highly effective. There's actually some good published data on this now. You can go ask ChatGPT or Dr. Google about PRP and sacroiliac joint ligaments. There's some good data on that.
Yeah, I agree. I usually start, if they want to do prolotherapy, I'll do a series of 3, but usually it'll take 3 to 6 treatments, or just PRP could be one and done. Yeah.
Yep. Is there a way you can send a link to download the site? You can't have the slides, but you can see the video. So if you go to YouTube, type in San Diego Orthobiologics as your search, you will find our channel. I think we now have 80 or more videos, and you're welcome to look at those and use them however you want.
Yeah, the video of the webinar today will be on there. We have to, edit, and then we'll post it hopefully in the next couple weeks. And then, yeah, you can see all the articles are on there, and all the articles I presented are available online. You could go online to pubmed.com and Google research, and you'll find all the articles. Some of them have the full length article that you can access.
That's right. We have a physical therapist who has a lot of patients who have questions about injections of different types. So, um, an open invitation to all our physical therapists. We love our physical therapists. We can't practice medicine without you. Many have come to our practice. Will spend the morning or spend the day with us. There's an open invitation to any healthcare provider who wants to come and learn and observe what we're doing. We find it mutually beneficial because we learn about what you do as well. Somebody says, which is more effective? The question is, I missed out on the beginning of the session. What do you use for knee arthritis? Which one is more effective? I'm assuming the question is, if the question is about corticosteroid versus PRP, hands down, Dr. Evangelista just made the case. Platelet-rich plasma in the long run is safer and more effective. Unfortunately, not covered by insurance at this point. There are questions that then come up about the durability of a platelet-rich plasma injection versus stem cells versus exosomes. And since Dr. Evangelista, you are sick of hearing me rant about stem cells and exosomes. Maybe I'll let you answer the question.
Yeah, we definitely don't use exosomes. It's not, there's no FDA approved indication for exosomes, so it's illegal in the United States, so we don't use it. Stem cells, we use the, microfragmented fat, adipose stem cells, or occasionally bone marrow, which has some mesenchymal stem cells, but very low numbers. In general, based on expert opinion, the fat and bone marrow should last longer than PRP.
So we have data. We have data. We have a database that we've been keeping for over 5 years now with thousands upon thousands of patients who've been treated with PRP or bone marrow or microfragmented adipose tissue. These are not stem cell therapies. We now have FDA-approved clinical trials that we've conducted. We have data on, and then we have expanded access data for which we use high-dose stem cell therapy. So that's another lecture you can watch where we use a high-dose a high-dose stem cell, sorry, MSC treatment, mesenchymal stem cell treatment. Just top of the head number, for patients who have mild to moderate osteoarthritis, PRP is sufficient, highly effective in at least 90% of our patients. The durability can be years, typically is 2 years from a single treatment. Based on my published data on using a true stem cell product from adipose tissue, that was an FDA-approved clinical trial, we showed 88% success rate at 3.5-year follow-up with patients with severe osteoarthritis, so much more challenging patient cohort, group of patients with some more severe osteoarthritis. So we did show good durability, 3.5 years. We're still collecting the data. It could be, if you look at most of the published data on what I would call a true high-dose stem cell therapy, not bone marrow, not microfragmented adipose tissue, not PRP, there's data now to 7 years showing efficacy, showing that patients are still doing well compared to their baseline. So for sure, it looks like the high-dose stem cell therapy has the highest durability, but PRP is more simpler to do. It's an hour-long procedure. So we can get into nuts and bolts on that later, but that's just sort of a overview.
Yeah. All right. You kind of answered this next one about how much stem cell and bone marrow versus adipose.
Yeah, there's a general decline sorry, spoiler alert, our bodies are going to get older and then eventually we're not going to exist anymore. So there you see this gradual decline in the mesenchymal stem cell in the bone marrow. That's been well documented. Dr. Philippe Hernigau, a friend of ours, orthopedic surgeon in France, has well documented the decline in the mesenchymal stem cell in the bone marrow. Typically by age 60, 65 is a pretty insufficient number of stem cells that remain. Fortunately, in adipose tissue, for whatever reason, biologically, we still retain a significant percentage of our mesenchymal stem cells. So the counts will be higher. I always say if you have a tablespoon of bone marrow concentrate, you probably have 50,000 stem cells. If you have a tablespoon of adipose tissue, you have about 500,000 stem cells. So a significantly greater number and good potency. But we've measured cell counts in patients in their 80s from their stem cells from their fat, and they still have very high counts. So I tell people, if you're still breathing, your cells are still working. Somebody asked about pluripotent umbilical cord stem cells. So as Dr. Evangelista pointed out, there are products that are being used in other clinics that are not compliant with FDA. The FDA clearly states that we, as physicians in the United States, are not allowed to use them. The sole reason for that is they have not been proven to be safe and they have not been proven to be effective, despite all the marketing claims that seem to be bombarding the market these days. So just do yourself a service, Google FDA and umbilical cord, or Google FDA and exosomes, and then you can see what they say about it. You don't have to listen to us.
Or you can go to Panama or Mexico. They do it down there.
Yeah. Okay.
Risk.
I wouldn't I wouldn't. Okay, I wouldn't.
I wouldn't either.
Um, there's some interesting data that you're going to hear about soon. Okay, so let's see. If your knee joint is currently bone on bone, is PRP effective in repairing the joint? So bone on bone is a term you hear tossed around. You have to understand the surface of your knee. So let's talk about the knee. You have the tibia. You have this cartilage that probably has a surface area of about yay big. Bone on bone could be a little tiny part of that. So you've just worn the cartilage pad completely thin, or it could be that you've just completely destroyed the entire cartilage. It doesn't really tell you the total volume of cartilage that has been lost. So unfortunately, it's a term that gets kicked around too much. But suffice it to say, if you have an X-ray and your doctor says you have bone-on-bone arthritis, you probably have severe osteoarthritis. PRP can be effective in some patients, but the response rate is not going to be as high as if you had mild to moderate osteoarthritis. Just to toss some numbers around, if you have mild osteoarthritis, success rate probably about 92% for significant pain relief. If it's moderate, it may be more in the 70s. And if it's severe, it's probably more in the 30 to 40% chance. So it's still worth considering if you're trying to avoid joint replacement, but just the expectation is that the success rate is going to be lower. Dr. Boggy in Italy shows good data for adipose and POP. What type of PRP do you use? I'm not familiar with Dr. Boggy. There is a Dr. Gobi, maybe that's what you're thinking of. Dr.
Gobi, maybe
Alberto
Gobi.
Gobi. I've Googled Dr. Rogers and Dr. Gobi. You'll see I've published several papers with Dr. Gobi in Italy, Milan, showing good evidence for microfragmented adipose tissue. The second part of that question is what type of PRP do you use? It depends, right? Depends. So if we're treating osteoarthritis, we want a very high dose of platelets, particularly if it's advanced osteoarthritis. If it's an area of the body that's sensitive, that we're afraid that there might be an inflammatory reaction, we make something called platelet lysate. And you can watch the videos we have on that, which is I would just characterize it as a kinder, gentler PRP treatment, less inflammatory, because we're really just trying to calm down inflammation. Um, there are other types of PRP we could talk about, leukocyte rich, leukocyte poor. We use it depending on what the individual needs of the patient might be. And sometimes we use different types of PRP in the same patient. Somebody commented, FDA doesn't approve a lot of things that work. The reason why we need an FDA is because what would protect the American society from any person coming up with any new idea that really wasn't proven to be safe or effective? But I do agree, they haven't yet approved a lot of things that work, but we have to prove that they work to the level of the FDA. Peptides falls in that category. Just do yourself a service, research peptides. There's a lot of very good data. Most of it is not clinical in humans. Um, when we first started treating patients with PRP 16 years ago, there were maybe 5 papers. So it may just be that the whole scientific community needs to mature. We need another 5 to 10 years to do more studies, but we shouldn't make claims ahead of that data. That's the point.
That's my next thing is I want to research peptides and see what the evidence really shows. So I'll be looking into that.
Well, peptides only is about 10 million different things. It's like saying vegetables. So yeah. So stay tuned. Stay tuned to this channel. We'll put together the data. Yes, we've done a deep dive into BPC 157. That'll maybe be another talk. Okay, thank you everybody for your patience. We're at the 45-minute mark. Any other questions? Oh, one last one for you, Dr. Ed, Dr. Evangelista.
I've had prolotherapy several times and need stronger solution. I'm 86 and heard PRP is definitely stronger if you haven't responded to prolotherapy. Depending on where you inject it, PRP sometimes is relatively painless if we inject it into a joint. If you inject it into a tendon, there's also going to be some pain with that or ligament. But into a joint, it's very painless, I would say, for the most part. So it depends on where you inject it, but PRP would be the next step after prolotherapy.
The pain with PRP to a large degree can be mitigated. We hear all kinds of stories. Oftentimes the injection technique is insufficient. The technique to anesthetize the tissue is insufficient. the volumes injected are too high. There's all these different factors that can influence pain. But even in a well-done treatment, there can be some discomfort, particularly in the tendons, as Dr. Evangelista just said. But the pain is typically short lasting, maybe 2 to 3 days for our patients. So I think the benefits outweigh the risks. Yeah, regarding costs, this comes up a lot. We're over time now, but basically with costs, it depends on what we're doing, depends on how many body parts we're treating, how extensive the damage is. For example, in the case of the spine, we treat patients all the time who have disc degeneration, joint arthritis, nerve inflammation. That's much more involved than, say, perhaps simple knee osteoarthritis patients. But we're probably looking at about $2,000 for a PRP type treatment done properly with the highest standard of care. So, okay, so we're happy to take any additional questions by email or by phone. Thank you for joining us today. Dr. Evangelista, thank you for a fantastic presentation of the evidence. There's way more evidence on our website. If you want to go to our website and look up the PRP section, there's that document you can download. And again, thank you for your attention.
Thank you, everyone. I'll post this webinar on YouTube and hopefully within a few weeks. All right, thank you.
Thank you.